Well, thank you very much, Rolf. A pleasure to be here this morning and talk about non-invasive ventilation, one of my favorite topics. And the title is Hypoxemic Respiratory Failure. So we'll be talking about non-invasive ventilation for a number of types of hypoxemic respiratory failure, as well as ARDS. Here are my disclosures. I don't think any of these are relevant to my presentation this morning, but I'll let you be the judge of that. There are certainly some ventilator companies that make ventilators for non-invasive ventilation. So I think one of the problems that we face clinically when we address the question of whether or not we should use non-invasive ventilation for hypoxemic respiratory failure is that there are a number of different causes of hypoxemic respiratory failure. It could be due to cardiogenic pulmonary edema, to postoperative respiratory failure, immunocompromised, pneumonia, or ARDS. And in fact, some of the literature that has attempted to address the question, should we use non-invasive ventilation for hypoxemic respiratory failure, has lumped together these causes of hypoxemic respiratory failure. So you don't know, reading those papers, whether the benefit, if there was one, was due to cardiogenic pulmonary edema, ARDS, pneumonia, or something else. So let's first talk about non-invasive ventilation for hypoxemic respiratory failure in the setting of cardiogenic pulmonary edema. And we actually have now several meta-analyses that have addressed this question. I think this is the most recent one, which is already about 5 years or more old, that looked at non-invasive ventilation for acute cardiogenic pulmonary edema and looking at the important outcome of mortality with the use of CPAP. There was a significant reduction in mortality compared to standard therapy. So CPAP better than standard therapy. Now the question is, some of you might ask, and I might ask, well, what about BiPAP? What about bi-level ventilation? So should we use CPAP, or is it okay to use bi-level ventilation? And in fact, in the same meta-analysis, they compared bi-level ventilation to CPAP, and in fact, there was no difference in mortality when those two modalities are addressed head-to-head. So I think we have good evidence from a number of randomized controlled trials, summarized now in meta-analyses, suggesting that either CPAP or non-invasive ventilation with bi-level ventilation reduces mortality in patients with hypoxemic respiratory failure associated with acute cardiogenic pulmonary edema. Well, what about patients who develop hypoxemia in the postoperative period, postoperative hypoxemic respiratory failure? I think this is an area where sometimes we don't think as much about non-invasive ventilation as we might in other types of settings. Here is a meta-analysis that was published in Critical Care Medicine about a year ago, where they showed that there was a significant reduction in mortality for COPD exacerbation, nothing new there. Acute cardiogenic pulmonary edema, nothing new there. But they also showed that there was a significant reduction in mortality when non-invasive ventilation was used in the treatment of postoperative hypoxemic acute respiratory failure. And in fact, the number needed to treat was only 11 patients treated for every additional life saved. So then let's drill down a little bit more on some of the evidence that supports this meta-analysis suggesting a benefit for non-invasive ventilation in this patient population. Well, here's a paper about 10 years old now, looking at the use of CPAP for postoperative hypoxemia. In this study, the patients with hypoxemia were those following major abdominal surgery who were randomized to either 7.5 centimeters of water of CPAP or oxygen alone. And they found that the PO2 improved more rapidly for CPAP than standard oxygen therapy. In addition, there was a lower intubation rate, lower pneumonia rate, and fewer ICU days in the patients who received CPAP as those who received oxygen therapy alone. We also have evidence, several studies. I chose here what I think is one of the better ones, looking at the use of non-invasive ventilation following lung resection surgery in patients who develop hypoxemic respiratory failure after that procedure. This paper is now about 15 years old, and a relatively small study where 24 patients received non-invasive ventilation, 24 patients did not receive non-invasive ventilation, and there was a significant reduction in the need for endotracheal intubation, significant reduction in hospital death in patients receiving non-invasive ventilation. So evidence that has been since followed up with observational studies suggesting a role for non-invasive ventilation in patients with hypoxemic respiratory failure following lung resection surgery. And then what about patients who develop hypoxemic respiratory failure following cardiac surgery? So here's a paper published a few years ago looking at prophylactic use of nasal CPAP following cardiac surgery. And they found that there were fewer pulmonary complications, hypoxemia, pneumonia, reintubation, and patients or subjects receiving CPAP, and that the ICU readmission rate was lower in the CPAP-treated subjects. So there is, I believe, evidence that we can point to for a role for the use of non-invasive ventilation, whether that is bi-level ventilation or CPAP in hypoxemic respiratory failure following surgery. Now, what evidence do we have for the use of non-invasive ventilation in hypoxemic patients who are immunocompromised? And here we have several studies that can inform our practice. There is this study from a few years ago in intensive care medicine that looked at the early use of CPAP in patients with hematologic malignancy. And here they show that compared to CPAP, which is here, the survival rate was much lower in patients who received oxygen by Venturi mask as compared to those who received CPAP therapy. And then there is this paper that many of you may be familiar with by Antononi, looking at non-invasive ventilation for treatment of acute respiratory failure, and this is hypoxemic respiratory failure in patients undergoing solid organ transplantation. And they show that with non-invasive ventilation as compared to standard oxygen therapy, there was an improvement in oxygenation and fewer patients requiring intubation in the group receiving non-invasive ventilation. And I think this is important because, as I'm sure you know, when we intubate patients with who are immunocompromised, those patients have very poor outcomes. So avoiding intubation, I think, is very important in this patient population. And then there is this paper by Ibert, published in the New England Journal now about 15 years ago, looking at non-invasive ventilation in immunosuppressed patients with pulmonary infiltrates, fever, and acute respiratory failure. Again, this was hypoxemic respiratory failure. It was a relatively small study of only 52 patients, and I think it's interesting how they applied non-invasive ventilation. So they applied non-invasive ventilation for at least 45 minutes every 3 hours. So this was intermittent non-invasive ventilation, if you would. And being a respiratory therapist who's worked in the field for now more than 40 years, this actually sounds a lot like what we did with IPPB back in the early days of my career. But that said, there were fewer patients in the non-invasive ventilation group than in the standard treatment group who required endotracheal intubation, died in the ICU, or died in the hospital. So I think we have some good evidence from randomized controlled trials to suggest some benefit for non-invasive ventilation in immunocompromised patients. However, we do also need to recognize this paper published in JAMA about 6 months ago that did not find a benefit for non-invasive ventilation compared to oxygen therapy alone in immunocompromised patients. So this was a negative study. That said, there were a number of methodologic problems with this study, not the least of which is that it was underpowered for what was their primary endpoint of 28-day mortality. So this study and the methodologic issues with this study have been debated subsequent, but I think in fairness we need to point out that there is one study, this study, that does not show a benefit but also does not show a harm for the use of non-invasive ventilation in immunocompromised patients. Well, what about the use of non-invasive ventilation for patients who have pneumonia with hypoxemic respiratory failure? So should we be applying non-invasive ventilation to these patients? Well, I think we are best informed regarding this question in a paper that was really not designed to look at non-invasive ventilation for pneumonia per se, but was designed to look at the potential value of high-flow oxygen therapy. And I'm sure Steve Hollitz is going to talk about this paper in more detail in a few minutes, but essentially what happened was that patients were randomized to high-flow oxygen therapy, standard oxygen, or non-invasive ventilation. And again, these were hypoxemic patients with pneumonia. And what did they find? Well, they found, and what most people point out from this study, was the benefit that they found for high-flow oxygen therapy. So the probability of survival was significantly higher with high-flow oxygen therapy than standard oxygen therapy. However, they also found that the survival was the lowest for patients who received non-invasive ventilation. So this study, although it shows a benefit for high-flow oxygen therapy, shows a harm for non-invasive ventilation. And if we look at intubation rate, we see the same kind of a result, highest intubation rate for patients receiving non-invasive ventilation. So a harm for non-invasive ventilation in patients with hypoxemic respiratory failure secondary to pneumonia. Now, I think a question that we might ask is, why is that? What is the potential, what might be a mechanism that would explain that? And I think a potential mechanism to explain this result is that with the addition of non-invasive ventilation, it resulted in patients having higher tidal volumes, and those higher tidal volumes may have led to poorer outcomes, as we now are all familiar with lung protective ventilation. And in fact, this study, which was published just this month or maybe last month in Critical Care Medicine, speaks to that. So here the authors looked at failure of non-invasive ventilation for de novo acute hypoxemic respiratory failure and the role of tidal volume, and they showed that the higher was the tidal volume, the greater the rate of failure, intolerance of non-invasive ventilation, and that was true whether they looked at mild hypoxemia or moderate to severe hypoxemia. So I think these results certainly demonstrate that targeting tidal volume between 6 and 8 mLs per kilogram of predicted body weight or ideal body weight can be difficult during non-invasive ventilation. In fact, it may not be achievable in patients who have hypoxemic respiratory failure, high respiratory drives, and then we drive up their tidal volumes even further by applying positive pressure ventilation. Now, I saved ARDS to last on purpose because this is what I think most people think about when they think about the use of non-invasive ventilation for hypoxemic respiratory failure. So I wanted to start with some areas where I think there is benefit and then finish with areas where I think there is not benefit. And one area where there's not benefit is pneumonia, as we just saw, and the other area where I do not believe that the evidence supports the use of non-invasive ventilation is for ARDS. So this is an observational study that was published back in 2009 during the H1N1 epidemic that we all lived through caring for those patients. And in Canada, they reported that about a third of patients with H1N1 infection and acute respiratory failure received non-invasive ventilation. So about a third of patients with hypoxemic respiratory failure due to ARDS and H1N1 received non-invasive ventilation. Note that 85% of those patients ultimately required non-invasive ventilation. So that's not very strong evidence whatsoever for the use of non-invasive ventilation in patients with severe ARDS, where the failure rate is approaching 100%. And then there was this paper we published about 5 years ago now, a little bit more than 5 years ago, in Respiratory Care, looking at the role of non-invasive ventilation in acute lung injury and ARDS. This was a proportion meta-analysis, and what they showed was that in patients with ARDS receiving non-invasive ventilation, they have a very high intubation rate, and perhaps more troubling, they have a very high mortality rate. And I would submit to you that this mortality rate may be higher than we typically see in current practice for intubated patients with ARDS. So this then is my summary slide. So when I think about hypoxemic respiratory failure and a potential role for non-invasive ventilation, I think about the categories of cardiogenic pulmonary edema, postoperative respiratory failure, immunosuppressed patients, pneumonia, and ARDS. And my read of the current literature is that certainly non-invasive ventilation, or perhaps just CPAP alone, is recommended for acute cardiogenic pulmonary edema. I think with the available evidence, we can also recommend its use in patients who develop hypoxemic postoperative respiratory failure. And I believe that the same can be said for immunosuppression in spite of the negative study that was published just last year in JAMA. In pneumonia, I think we have to be very careful, and I would not recommend the use of non-invasive ventilation in patients with hypoxemic respiratory failure with pneumonia, where I may recommend actually high-flow oxygen therapy. So I'm giving you a little plug there, Steve. And for ARDS, the available evidence I don't think the available evidence supports the use of non-invasive ventilation in ARDS. I do not think that it's recommended there. And when we use non-invasive ventilation, I think it's very important that we monitor the tidal volume. I would hope that every one of us in our care of intubated mechanically ventilated patients would be paying attention to how big is the tidal volume and targeting lower tidal volumes. I think we now have evidence to support that that should be the case with non-invasive ventilation as well. So with that, I will stop and turn the podium back to the chair. Thank you.